Welcome everyone to the AMA webinar, Healthcare for People Experiencing Homelessness. My name is Sophie Rowe, and I'm a current MD, MPH candidate and Chief Coordinator of the Street Medicine Institute Student Coalition and an AMA member. This webinar came about as a result of the AMA Medical Student Section accepting the Street Medicine Institute Student Coalition's request for increased programming that raises awareness of the homelessness crisis and educates healthcare providers and trainees on the best practices in caring for people experiencing homelessness, as well as advocacy strategies. We hope that we can all use what we learned tonight to improve the quality of care for our patients experiencing homelessness and promote real solutions to this crisis, ultimately working toward an end to homelessness. I will now introduce our speakers for tonight. So we have Dr. Joshua Barocas and Ms. Melissa Moore. All right, so Dr. Barocas is an associate professor of medicine at the University of Colorado School of Medicine and an infectious disease physician at Denver Health, Colorado's largest safety net hospital. He leads an interdisciplinary research program that is involved in a large clinical trials, epidemiological research, and simulation modeling with the goal of improving health outcomes among marginalized populations, such as people experiencing homelessness. His research program focuses on vulnerable populations, including people experiencing homelessness, and his work has led to clinical and policy changes at nearly every level. His lab is also embedded within the Social Determinants of Health and Disparities Modeling Unit at CU, University of Antwerp, of which he is the director. This unit provides infrastructure for a cadre of investigators on campus and connects us with community organizations such as Colorado Coalition for the Homeless. His work has appeared in prominent journals, including the New England Journal of Medicine, JAMA, Nature, and Annals of Internal Medicine. He actually just had a new piece come out last week. Some Moore is a current board member of Street Medicine Institute and founder of a nonprofit provider in the San Francisco East Bay area called RISE, Rising into Self-Empowerment. She is a person with lived experience of 7 years in the East Bay area, 4 years employed with the street medicine team, operating through a local federally qualified health center as a community health outreach worker, and now she is founder and director of RISE. She also has a degree in medical assisting and is trained in substance use disorder harm reduction, is also certified as an administrator and distributor of naloxone. RISE is a street outreach organization composed entirely of people with lived expertise in homelessness that brings the unhoused food, water, hygiene items, and other camp supplies. Along with outreach, she and her colleagues link clients experiencing homelessness to medical, legal, and housing resources, along with safety net services. She uses her extensive experience as a community health outreach worker to advocate for people experiencing homelessness and advise the Street Medicine Institute. All right, so now I'm going to turn it over to Dr. Barocas.
Thanks, Sophie, for that lovely introduction and for helping get this webinar launched. And thanks to the AMA for sponsoring it. So we have 3 goals for you tonight. The first is going to be talking about the health risks, the specific health risks to people experiencing homelessness. The second is really the right approach to clinical care. And third, we're going to talk about advocacy strategies. Now, all 3 of these we're going to try to go almost as fast as we can through them so that there's time for question and answer. So if it seems like you're getting a whirlwind tour of everything, you are. So I'm going to start. Health risks to people experiencing homelessness. There is no better way to summarize the health risks for this population than this. People experiencing homelessness die on average 30 years earlier than other people in the US, which is the average age that Americans died in 1900. So if you remember one thing from the 10 minutes that I'm talking, it's that. But let's also remember that the health risks are outsized in historically marginalized populations, specifically marginalized racial groups. So We're going to just break this into four big clumps. There are so many things that we could talk about, but we're just going to try to condense it. First, we're going to talk about climate-related health risks. The greatest health effects of climate change are being felt most acutely by people living in poverty and people experiencing homelessness. In the summer, heat exposure can cause heat exhaustion, dehydration, heat stroke. In the winter, cold exposure causes injuries such as frostbite, hypothermia, which all can inevitably lead to death. Older adults, people with substance use disorders, those experiencing chronic homelessness are also at increased risk of these health effects from extreme temperature. And malnutrition, which is common among people experiencing homelessness, decreases a person's capacity to tolerate cold and heat. So there does appear to be a sort of a compounding effect of cold weather, warm weather, malnutrition, and of course, we can't ignore the effect that opioids and opioid use disorder can have on people's health during the cold and hot months. Second, moving on to violence, suicide, and trauma. History of violence, suicide, trauma are essentially nearly ubiquitous in this population. There's a 2012 study that found that suicide rates were 10 times higher for a cohort that had experienced homelessness compared to the general population. Another found that more than half of people experiencing homelessness have had thoughts of suicide or have attempted suicide. And the one that generally sort of sends shockwaves through my heart, 80% of unsheltered women report abuse or trauma as the cause of their homelessness. Now, it's not uncommon for people who are unsheltered men, that's about 40%, or sheltered women, about 35%. But I just want you to think on that. As we think about the people that we see on the streets, the people that are coming into shelter, that are looking for respite, somewhere between 35 and 80% of those people have had some sort of abuse or trauma that has led them to where they are. Okay, next, I'm an infectious disease physician. We have to talk about infectious diseases. People experiencing homelessness do have higher rates of HIV than people with stable housing, as well as virologic non-suppression. CDC estimates that at least 17% of people with diagnosed HIV experience housing instability at some point in their life. Now, all of this should just raise a red flag. It means that we're not doing enough for the people who are at risk or have HIV. It doesn't mean that we should systematically exclude people without stable housing from care for HIV. In fact, a number of studies have shown that people who are experiencing homelessness with the right supports can do exceptionally well on antiretroviral therapy and have outcomes similar to people who are housed. So let's not discount people just because they are unstably housed. Now, there's a ton of evidence out there that homelessness or housing instability can substantially contribute to the population burden of disease for tuberculosis, for hepatitis C, for hepatitis A. We've seen outbreaks, and most recently, obviously, COVID-19. I do, though, want to highlight there are a ton of other infections that many of us who are housed don't necessarily have to think too much about. Bartonella was found to be shockingly common among people experiencing homelessness in Denver, Colorado a few years ago. There's also a huge disparity in the risk of invasive uh, meningococcal disease in this population, largely because We don't necessarily have the right outreach efforts for vaccination. Now, those are just a couple illustrative examples of communicable diseases. Of course, I would be remiss if I didn't include body lice, scabies, bed bugs. These are easily transmitted through close contact and throughout the shelter system. I want to also highlight in the context of now, we have a rising syphilis epidemic essentially in all corners of the US and among all demographics. When you come in contact with people who have been experiencing homelessness, it is the right thing to do to screen for syphilis, just as you're screening for HIV, for hepatitis C, because we are not going to get control of the syphilis epidemic without making sure that our most vulnerable populations uh, are treated. Now, finally, and I told you this is going to be a whirlwind. There will be time for questions. There are non-communicable diseases as well. These largely include substance use, mental health, cardiovascular disease, and cancer, as well as liver disease. Half of people experiencing homelessness have had or have a mental health condition and or a substance use disorder. There are higher rates of injection drug use, as well as non-fatal and fatal overdose than people who are housed. That is because we don't get to them. We don't bring the medications to them. We don't bring the harm reduction to them in the droves that we need to. Study, excuse me, study not too long ago, uh, done by Danielle Fine and some of her colleagues in Boston showed that overdose rates among Boston's homeless population were 12 times higher than that of the general population. So as we think about the overdose epidemic in the US, often overlooked are our most vulnerable of our most vulnerable. And that includes people who are experiencing homelessness. So I'm going to bring it back. All of this is just a brief snapshot of all of a variety of the health risks that people who are experiencing homelessness just live with on a daily basis. People who experience homelessness die on average 30 years younger than other people in the US, the same age as people died in the US in 1900. We can definitely do better.
Mhm.
So, with that, I'm going to pass it back over. My 10 minutes is nearly up. Sophie, will you be passing it to Melissa, or should I just pass it over?
Thank you so much, Dr. Barocas. That was for that extremely enlightening presentation of the health risks. I think you did a fantastic job of taking us on a whirlwind tour, but it's all very sobering to hear, even though I've been involved with this issue in trying to learn as much as I can throughout medical school and even before during my undergrad. Whenever I became like stunned by the homelessness crisis and its health repercussions on health and public health, I've learned a lot of new things just from hearing you speak, especially regarding infectious disease burden and just how bad the overdose disparities are relative to our larger population. So next, we are going to be hearing from Melissa Moore, who again is a founder of Rise, which is a nonprofit that serves people experiencing homelessness. And very uniquely, it's actually composed completely of people with lived experience of homelessness, or as we say these days, lived expertise. Um, and that is a huge point that I would just like to quickly draw attention to before Melissa. I hand it over to Melissa because really it's a best practice. Many research studies and really organizations that have been doing the work of street medicine, which is the provision of healthcare to people directly where they are on the street, have found that actually it is incredibly important that people who've lived through homelessness themselves are part of the multidisciplinary healthcare teams that are going out to engage people who are currently experiencing homelessness. And so Melissa's organization that she founded really addresses that need. And I think it's a great model for all of us who are hoping to care more, do more to work with this population of people experiencing homelessness. That we always are integrating people with lived expertise onto our teams and really amplifying their voices and their advice in the process. So
I am so
with that, I'm going to hand it over to Melissa Moore, again, founder of Rise, who's going to carry us through some guidance on the advocacy strategies that we can all use to advance health equity and improve healthcare and also improve the lives of people experiencing homelessness and hopefully work towards an end to homelessness. So, Melissa.
Thank you so much, and I apologize. I'm not sure what happened there. It dropped me. I'm so sorry. But thank you for the introduction, and thank you, Josh, for the prior health risks that you laid out. And welcome everybody. I'm just going to talk about healthcare for people experiencing homelessness, and the impact street medicine has on people experiencing homelessness currently. It's a growing movement, and outreach model brings healthcare directly to the people experiencing homelessness by meeting them where they are, meaning on the streets, in encampments, or any other and shelter location vehicles. And this bridges the gap for individuals who face various barriers to accessing basic medical care and creates a connection for providers to build trust and engagement, which is crucial for improving health outcomes and saving lives, which is why what we need to do as a medical provider and street health outreach. And it's been saving lives. It's when I was in the camps, I have 7 years lived experience. When I was in the camps, we didn't have street outreach, street medicine outreach. We only had street outreach. They brought a bottle of water and maybe a bag of chips. With the street medicine teams going out there right now, it's bringing healthcare to people that will not, for whatever reason, will not go access it on their own. So in that frame, we do it. We try to do it as a patient-centered model, multidisciplinary approach to street medicine, and which means that the street medicine team integrates healthcare and social services and advocacy to meet the complex needs of people experiencing homelessness. And key team members may include medical providers, such as the primary care, medical providers, I'm sorry, including the nurse practitioner or PA, and the RN who can assess and treat a patient at the point of contact in the field, which is extremely important. Then you have mental health specialists who may or may not be on the team for outreach. They can link you to therapy or medication support, which is well needed for all the behavioral needs out there, behavioral health needs and mental health needs. It's huge out there, and it coincides and goes hand in hand with substance abuse disorder. So, when you get one linked together with the other, then hopefully you can get them both taken, take treated. You can do access referrals into rehabs, and you can do also access referrals into therapy at the same time, which is amazing. And that's what's definitely needed out there because I feel like the behavioral health part of it is their safety net is so thin out there. And that's what creates, disengagement and creates isolation for people out there experiencing homelessness. Also, with the rights taken away, and the sweeps, it keeps you oppressed. And so mental health is really desperately needed currently out there on the streets. Case managers are also on the multidisciplinary team. They navigate benefits, housing, NIDs, and submit referrals for legal and other specialized resources. CHWs can also do that, which is a community health outreach worker. But usually case managers are the ones that take lead on that. And then you have the community health outreach workers, and your best community health outreach worker will have lived experience. And you know that right now because we are the first to engage when we go into an encampment or an area with our team. And we know by experience had the feel of the place, the vibe. Just we are aware of things that most people aren't aware of when we're walking into an area, and so we yell out, we announce ourselves, and when we go into an unknown camp, community health outreach workers with lived experience can interact with the first person they come to on a different level than, say, a member of the team, like nurse practitioner, RN, that has not had experience, out there in the camps, because we speak a different language. We speak street, and they recognize that. So that builds trust right there, and connection. So you don't have to really stretch for that. And so we're usually allowed in, and um, it does definitely helps with engagement with the team. We also hold space for listening, active listening, the CHWs, and we can de-escalate situation from skills we have, lived experience, and we provide harm reduction supplies. Most teams do. I know that we did, and I still do. When I was with my prior team, and now went with Rise, we definitely go out there with harm reduction supplies and naloxone and training and information, because it's so important right now in this age of the opiate, fentanyl, xylazine, all that stuff. That's this crisis is just the epidemic is incredible across the country, and it's taking lives so fast. It's like nothing we've seen before. I mean, heroin was bad with opiates, but now this is just, hundreds of times worse, and it's needed to be brought out there, and people need to be informed. And I'm always surprised that people aren't informed that or don't know about the xylazine that's in fentanyl, and they're surprised that the naloxone won't take care of that. So yeah, more information definitely needs to be put out there on that. But there's also innovative practices in street medicine that we are trying to institute and have been instituted in some areas of the country. Includes ultrasound at the point of service, and which is hugely beneficial. It supports early diagnosis of internal conditions and helps the physician's assistant or nurse practitioner be able to diagnose on the spot more accurately than they could, by just going along with the symptoms. And that's being rolled out, and there are street teams that I know that are actually using it and getting really great results with it. Um, Reproductive health, birth control, including contraceptives, ensures individuals can make informed decisions, and they can take care, protect themselves. Safe sex practices, and things like that need to be that we bring out to them. Harm reduction services, I just talked a little bit about that, but we definitely bring out fentanyl testing strips, naloxone, and information that promotes safer practices. It's not about them using; it's about them using safely, and that's what saves lives and stops the spread of infections. If they're using safely, then we have they can, I mean, people can do whatever they want to do. It's a free country. We can't stop anybody, and we want to make sure they're doing it safely. That's our job as medical professionals, is to reduce this spread of infection. So no judgment. And in fact, there are a lot of people unhoused that do use substances to cope with the daily traumas of living on the streets, and just a struggle. Once they get housed, I've seen many people that I've done referrals for, once we get them in housing, that want to quit, and then they're successful in going into recovery. It's not that they want to use; it's just that they are, because of the situation they're in. So let's make it safe for them by bring out harm reduction supplies, and then also vaccines and preventive care. Teams are now able to go do vaccines in the field. We did many COVID vaccines, and flu shots, and also we can draw blood work in the field, by the RNs can, and also perform HIV and HCV rapid testing, which is hugely important. And then we can provide linkage to the clinics that actually specialize in the treatment and counseling of the people that do test positive. That's another harm reduction aspect too, to stop the spread of any kind of infectious disease. And then so offering these innovations alongside fundamental care, such as wound management, chronic disease treatment, and mental health support, street medicine transforms how healthcare reaches and serves the in-house population, and ensures care is not only accessible but also tailored to the realities of life on the streets, which is not a pleasant reality. So when you come with a team into the encampments, and you bring yourselves authentically, and you hold space for them, and they see and they build trust and connection with the people that you're serving in a servant's position. Never stand over them. We always sit with them or kneel down with them, so we're on eye level with them, because that's now we're peers. Now we're equals. We're not, doctors or anybody else, law enforcement or anybody else standing over them. We are on equal ground, and that goes a long way on building engagement or creating engagement and building trust and just letting them know that we are there, as ourselves and nobody else, and we're there to help them, no judgment. And that's how we engage. That's the best practices way of engaging people when you go out into the encampments. Having said that, also advocacy is huge. When with street medicine teams and physicians, nurse practitioners, RNs, all the way down to community health outreach workers, communities, everybody now in this day and age of post grants pass and other things, we need to arm ourselves with rights, the rights that we have left, that they have left, the rights for them, and educate them on their rights, and educate them what can and can't be done, and empower them. We need to empower them. That's our job, also, not just street medicine, but empowerment and advocacy is included now. And that's we're trying to get that to include the new framework of street medicine because it's so important. Like Josh was saying, these sweeps and people lose everything. They lose their medications, they lose their rights, they get re-traumatized, they lose medication, they lose um, such important things, pets, they lose anything and everything. They just take it like and they throw it away and swept like a piece of garbage. And so that's re-traumatization over and over again. And a lot of times we as service providers are working with them. We have consultations or referrals that we've gotten approvals for. We've gotten housing matches for them. We have gotten different things, and we go out to find them in the encampment. It's been swept. Now we have to go look for them. They're scattered. We have no idea where they're at. Sometimes we find them in time. Sometimes, most of the time, we don't find them in time for their consults, their appointments, and or their housing matches. So it goes right back to, starting over again. And sometimes we never find them at all. So it definitely is yeah, that's part of the advocacy section. So I'm going to actually stop right there. And if you want to up the screen for the advocacy, and Josh is going to start that off with the advocacy part of it. And yeah, definitely welcome questions at the end of our presentation. Sorry, honey, got going on the advocacy. That's just me. Sorry, my bad.
No, thank you so much, Melissa, for painting such an illustrative picture for us of what it looks like to provide healthcare to people experiencing homelessness, specifically through the street medicine model, which really brings the healthcare and the social services to the people. And thank you also for jumping into the advocacy strategies. I myself, when I introduced you, jumped right into them as well. So that just shows how we always partner the advocacy with our efforts to provide care to people experiencing homelessness, whether we're seeing them on the streets or whether we're seeing them at the hospital and emergency department. So now I'm going to transition it back to Dr. Barocas to talk more about advocacy specific steps that we can take.
Well, I first have to say, Melissa, the work that you and your team do is it's just amazing. And if anybody has the opportunity to look at the work that Rise does out in the Bay, you should 100% go spend the rest of your evening Googling and looking it up. It's really just quite amazing. So thank you for everything that you do. So Melissa and I talked about how to set up this advocacy is such a huge word, especially in this space. And so we really thought about, well, how can we in the next, 10 minutes set up this discussion around I want to do something.
Mhm.
So um we thought that the best way to do it was to use a case study. Now, of course, you've heard tonight 1,000 different issues that we could all sort of rally around. We're going to focus our advocacy discussion tonight just for us. The question and answer can include whatever you all want. But we're going to focus our discussion on sweeps, involuntary displacement, as an illustrative example. and that's it, right? So we can't tackle everything, but we can talk about the types of advocacy we can be engaged with on a specific topic. So what better way than essentially to talk about what is perhaps the most out there topic in homelessness right now, which is what is happening at the local, state, and federal levels uh, with people who are unsheltered in encampments. And encampments can mean a lot of different things. In various cities, it means that you are sitting on the sidewalk alone. An encampment in another city has a specific size. So we thought we'd tackle it that way. You know, Melissa, I'm really curious. Um, if you were to give sort of one right now in the middle of all of this, if you were to give one thing that you want everyone on this call to do or that they could do around sweeps. And again, illustrative example, right? But around sweeps, what what would that one or two things be that we could advocate? Like, how could we advocate? I have mine, but I wanted to ask you first. I can go first if you need.
Right. No, that's a good question. That's a great question. And everyone on this call is involved in some layer of the healthcare system, whether they're providers or AMA or national healthcare provide any kind of organization. And I feel that it's everybody's right and everybody's duty to stand up and talk about the sweeps and make statements publicly on your websites, make statements on your organization's websites, make statements in social media because coming from someone in a professional capacity, the public in the community and in the legislators and the governments more are apt to listen than to just like someone like me, just like, hey, so, I mean, it comes from the higher up you are, the more important you possibly can be, are in these scope of things, the more they will listen. And everybody should make a statement. Everybody needs to make a statement against these sweeps because they're killing people. They are killing people. And we don't do that. That's not what the, your oath is, it's not what morally you're supposed to be doing, and so we need to just we just need to make statements. Statements are huge right now from any sort of aspect of provided, like I said, provides all up to the AMA.
Yeah.
Anybody, yeah. Just putting it out there about this what sweeps do to people, like Josh was saying, and what's happening and what they're taking away. They're making us go backwards in providing healthcare for the homeless. Period. I mean, by losing out on referrals, like I was saying, employment. Sometimes we don't even find them. Sometimes they pass away.
You
You know.
know, one of the things, Melissa, that's worked, at least in our local
Mhm.
level, um, I'll say two things from a medical professional researcher stance. We oftentimes use way too many statistical words, and for a policymaker, for a legislator, one of the things that we have tried to do once the data show, here's the evidence against a sweep or against this sort of line of thinking or for this line of thinking, is to make the messages digestible. Not everybody, including most, medical professionals, knows what, the convoluted methods that we're using are. So distilling some of those messages into policymaker talk. I think we forget that while this may be something that you and I think about literally every day, it is one of 700 different issues that any given mayor, legislator is tackling on that day, making the message short and sweet and applicable. The other thing, and I don't want to monopolize, the other thing that I have in sort of the advocacy strategies realm of the world that I've applied in the sweeps world, and I think is pretty ubiquitous, is, you know, we talk about stages of change. Just bear with me for a second because I have a line of thought. But we talk about stages of change when we're trying to get someone, let's say, to quit smoking. Someone may be pre-contemplative, contemplative, they might be in their action stage. This idea, and it really comes to the meeting people where they are sort of idea, whether it's harm reduction or not, but we don't walk into every appointment saying, you absolutely have to quit smoking. We ask the question, hey, are you ready to quit smoking? Where are you? Have you thought about this? And I think that if we take that same general approach with our advocacy strategies, with lawmakers, policymakers, other stakeholders, community-based organizations that want to get in the game, right? Or may not know how.
Right.
I think that tailoring those messages, but first understanding where they are. We have a lot of legislators who want to do the right thing and need that sort of support because they're in the I forget my stages of change, all of them, but let's just say that they're in the action stage. They need that support. They need to know that they're doing the right thing, the daily affirmations, you have support from the AMA, you have support from National Healthcare for the Homeless, you have support from all of these people, where somebody in the pre-contemplative stage simply needs to know that the door's open. Doors open to discuss this. If we demonize people at any level, we're shutting that door. If somebody walks into my office and says, or if I walk into some patient encounter and say, I'm not treating you unless you quit smoking, that appointment is over. That
Mm-hmm.
relationship is broken. And if we approach that with our community leaders, hey, where are you on this? We can help. We've got the evidence, we've got community voices. What do you need to hear? Where are you? I have found that to be effective. I don't know if that's been your experience too.
I'm actually glad you brought that up. And that's exactly been a lot of our experience, my experience also in advocating is collaboration across the board. And when you go to present things to, whoever you're presenting it to, just, have that backup and grassroots advocacy groups are huge right now. Serve people with lived experience and telling their stories and putting that out there. But community engagement involvement is huge. We are doing one coming up with our community and answering questions. We do a panel of lived experience people up on the stage, and they ask questions of us, and we answer back. And then we get on board to get people on board advocating for change, for policy reform, for going forward for solutions. And so definitely collaboration across the board and asking small, don't like, send off a letter like 2-page, essay of like why you should do this and you need to do this. And, I stand on International Bill of Human Rights. I'm always talking about, but I'm not going to threaten somebody with it. I just
Right.
want to make them aware of it. You need to make people aware of the rights and of what's out there. Right now with the encampment sweeps, we are pondering, and we're going to probably institute finding reasonable accommodations for people that are disabled in certain camps that haven't been swept yet, and ask and telling, and they ask of those reasonable accommodations per ADA guidelines. We're say this person needs 2 weeks to be able to move their stuff, because of their disability and things like that. So we're looking for like loopholes now. Since the advocacy, we kind of says back quite a bit with the grants pass ruling. So now we're looking for reasons, why we can show them, hey, you can't just come in and sweep within 24 hours of these people. They're a lot of them are disabled. They can't move like you want them to move. They're going to lose everything, in their medications and everything important to them. So yes, definitely thinking of different solutions, not throwing everything at once at everybody, like you were saying, or demanding never gets anywhere. That's you're just being bullied at that point. So yeah, you definitely have to approach with advocacy with a definitely a assertive tone, but not aggressive. And I definitely agree with everything you said for sure.
And with that collaboration, I think that in this space, and not to veer too far off of the sweeps, but we are just talking about advocacy strategies in general. Um, with this topic of homelessness in general, but also just using this as an example of encampment sweeps. This is a cross-cutting issue that has to do with, excuse me, legal rights. So there are human rights activists that want sort of a seat at the table. There are medical providers, healthcare providers that want to help. And of course, there are, and I'm going to exclude somebody and somebody's going to get mad. I'm just going to stop there. But then, of course, there are people with lived experience. And it used to, I'll say, just in sort of, because it's really just the three of us sitting here talking and nobody else is, I have to remember that otherwise I'll get super nervous. Um, is that I used to, when I would meet with lawmakers or policymakers, it would really bother me that my data was not enough. That, oh my goodness, this was a really well-informed study that either we did or somebody else did. And why is this not enough? And of course, it's not, because lawmakers also respond to anecdotes and personal stories. And so I actually think that this merging, one of the things that we have going for us is that we're able to sort of come at it from three different angles. There's the data angle, there's the sort of lived experience of the healthcare providers who can say, this is what I see and this is what I'm treating. And then the the third, and I think honestly, the most important is are the voices of people who have had that lived experience. And so bringing those three voices to the table actually sometimes doesn't give people the out, right? So we're saying, look, this is what I experienced. I'm a constituent, and if you don't listen to me, then fine, we got the doctor over here. Listen to her. And if you don't want to listen to her, listen to the researcher who knows the data and is looking at this from a population level. And really, you start to triangulate a very strong advocacy message. And of course, my last thing that I'll say, and I'm really curious for you, Grants Pass, as an example, is this huge issue. It's a Supreme Court case. It is a now federal law, except that it has local implications. And so often we want to go to the biggest level.
Mhm.
But honestly, right now with Grants Pass, it's local efforts. Just because grants pass happen doesn't mean that it has to be implemented, right? It doesn't mean that a city has to displace people. It doesn't mean that they have to fine them or throw them in jail. It simply means that they can. So now is the opportunity to pull together those sort of adjoining forces and say, all right, well, let's go local. How do we organize locally on this issue? And again, we're just talking about sweeps. We could be talking about any issue in homelessness at this point. Um, but but to me, all of this work right now needs big support, big statements from organizations like the APHA that put out a policy statement last year, or the AMA,
Mhm.
so that you and me, can walk into a lawmaker's office locally and say, hey, we've got all this behind us, but really we're just two people that want to tell you our story.
I think that's amazing that you just model that out. It definitely would be hugely impactful. With different aspects, like the triangulation that you talked about, and coming to someone with that, you can't, recognize or not do something. It's not a set of data. It's actually anecdotal, and also with physicians and what they witness. So it's basically that's a perfect scenario of advocacy right there. And getting people together to do that is amazing. We here in California, the governor signed an executive order on after grants pass. giving the cities and every kind of counties and everybody right to just sweep people. So we have an extra layer of like, sweeps going on. Um, I was on a bicycle ride 2 weekends ago from Oakland to Sacramento to our state's capital, and we all rode our bicycles there, 2 day long trip to advocate for against camp and sweeps and for rights and for just some sort of solutions or some sort of because that's where the governor's at. So we went to the governor. We're like, why'd you do this? We didn't get to talk to him, of course, but we did that and we publicized it. So we're showing that we were in solidarity and writing, and a lot of people followed us, and people thought that that was unique and a great way to advocate. And we had different people lived experience, couple service providers, the news, just riding a bicycle to the Capitol was a huge, and that's a great way to advocate because you get people together as a community. Any kind of community could be doctors, like I said, the triangulation theory of doing that, and that's perfect.
Yeah.
So any kind of things like that, just to put it out there that this is what we're writing for, and this is our ask, and that's it.
It's a simple ask. And
Hmm.
I know that we're probably coming up on the time where we should
Oh
do
yeah,
Q&A. And
yes.
we probably should have said this at the beginning, but if you don't know grants pass, in June, the Supreme Court of the United States issued a ruling that allowed local government ordinances with civil and criminal penalties for camping on public land. So it does not constitute cruel and unusual punishment for people experiencing homelessness. So essentially, it allowed people to be swept or displaced, jailed, fined, um, because it did not constitute cruel and unusual punishment. And before I hand it back over to Sophie, I will say that in the dissent, um, excuse me, uh, I think it was Justice Sotomayor said that we were criminalizing or that sleep was a biologic necessity. And we were criminalizing sleeping, which I thought was very beautiful and brilliant. Unfortunately, it was the dissent. So Sophie, sorry, I know that we have Q&A.
No, thank you so much, Dr. Barocas and Melissa, for walking us through such fantastic advocacy stories. And thank you for the case advocacy strategies, rather. And thank you so much for the case study as well, and for providing all of your individual anecdotes of your experiences in advocacy. Dr. Barocas, I think now we will all come to speak to our local policymakers with that in mind. You have to come to them and help them understand the issue in a way that's approachable to them, right? So now I'm going to transition us into a Q&A period. We really appreciated the audience questions that came in already. So the first question I'm going to ask of Dr. Barocas to answer first, and then Melissa to answer. So, how can we provide continued care and improve health outcomes in people experiencing homelessness, or rather, patients experiencing homelessness?
How can we provide continued care?
Continuous care, yeah. And I think what might be helpful, because we focused a lot on street
Yeah.
medicine specifically in this conversation tonight, if we could talk a little bit about if you're seeing a person who's experiencing homelessness in a hospital setting, in an emergency department setting, how can we make sure they can get continuous care if they're spending some of their time outside in shelters moving around?
Absolutely. So, it's a great question, and I think probably a multi-million dollar question. Excuse me. So, assuming that we get to a point, or we're at a point where we unfortunately have somebody in the hospital, and that our outreach either didn't go far enough or circumstances were too much. When people come into the hospital, just like for smoking cessation, just like for uh, diet, this is a reachable moment. The problem is that we don't ask the question, and we don't have a good way, sort of unified approach of documenting homelessness or housing instability. And so the first thing and the easiest thing is good documentation. That is by far and away, if you're a medical student watching and you're wondering, well, what can I really do? I'm a medical student. Your documentation is vital so that we know that this person needs additional services. Second is that there uh, is a when they are in the hospital, it is a good time to have a multidisciplinary team approach. Now, some hospitals do this well because they have a lot of people experiencing homelessness. Some hospitals don't, simply because it's not really within their purview, whether because of location or size or whatnot. Regardless, I think that a multidisciplinary approach and at least some sort of algorithm of saying, okay, we've got somebody here who is hospitalized, who is experiencing homelessness, and coming in with, and there are a ton of tools out there to say, what are the needs of this person? What's a safe discharge plan? And as we are expanding services, it's really important to have bridge services. So places are, we want to talk about places where we can expand access. Excuse me, it is definitely in respite care. So respite care offers people the opportunity, once they're done with their hospitalization, to sort of just continue to get a little bit back on their feet, potentially find transition, work with a case manager or social worker to get transitional housing. And through this whole process, if you take the patient oriented approach, that this is a person, like I said at the beginning, that has likely experienced a significant amount of trauma, has experienced a life that many of us would not have survived, then approaching them as a patient that has different needs than, say, me with my knee replacement, um, can go a long way. It can prevent premature or patient-directed discharges. It can prevent red flags or yellow flags coming up, which are things that go with people and actually perpetuate the cycle of homelessness. So I think that even as an individual walking, individual medical student, resident, intern, provider, nurse, etc., walking in and saying this person's life experience is such that I need to approach it differently, can go a long way.
Thank you so much, Dr. Barocas. I know that myself and a lot of the other medical students on this call will appreciate that advice and always keep it in mind. And I just want to add, it all starts right with, if you're not sure, maybe just asking in a non-judgmental way. So where are you staying at night? How long have you been staying there? Is there anywhere where else you're staying? So that you as a healthcare team and or healthcare provider or others who care for them can make sure that they know where they're located in the city or community, and document that, oh, this person stays at XYZ shelter, they stay on the street, in the medical shared, as you mentioned. So now I'm going to pass that question over to Melissa. So Melissa, the question is, how do we provide continuous care to people experiencing homelessness, specifically as they're transitioning maybe from living in the street to moving around to different shelters, and then going to the ED, going to the hospital, and continuing to, and then going back to the street? How do we make sure we can provide continuous care to them? Dr. Barocas talked a little bit about documenting it from a medical standpoint, but from your point of view.
Just from a street medicine point of view, and just from a case management point of view, definitely continuous care is difficult at times. But we stay with our patients from the beginning to the end. Just constant contact. Whether it's, a lot of people don't have phones, so it's hard to do that. But if they do have phones, we keep them updated on their appointments. We schedule them for them. And if they don't have phones, we go there. We pick them up. We find them. We pick them up, get them to their appointments. We do have respite in our county. I do respite referrals, and that's an excellent way of getting them, the healthcare they need. And then we're able to keep in constant contact and case manage, by going to them at the respite. But not everybody has that option. So you just need to keep going and keep constant and do the referrals. Make sure they go through. If they're not going through, bother your referral department. Just be a proactive, basically proactive by continuous care because it can be hard, especially if they don't have phones and they get moved a lot. You just have to be there and look and just usually ask them if you get moved, where do you think you might go? If you get swept, so we know have an idea where they go, and just keep stay with them until the end. You from the beginning to the end, you walk with them, you support them, and you empower them, and especially if they get housing matches, that transitional support is so important. Because a lot of people will go back to the streets so rather than keep staying in housing because they're so not used to it, and they get uncomfortable and they leave back to camp, which is crazy, but it happens. So we need that transitional support also.
Thank you so much for that, Melissa. I think your response really draws attention to how we, as providers, have to be focusing on, we really can't provide care to this person that they need on our own. We have to be learning what resources are in our community. Is there a street medicine team? Is there a medical respite in our community that we can connect this person to? So now I'm going to transition over to our next question, which is, what are useful resources for medical students to learn about healthcare for people experiencing homelessness? Well, one that I'll add in addition to listening to this webinar, so the National Healthcare for the Homeless Council provides a lot of incredible learning resources. You can just go to their website. We're also going to provide a 2-page document that really summarizes what we discussed tonight and can serve as a toolkit for you as a medical student or provider to use whenever you're working with patients experiencing homelessness in the variety of medical settings. Additionally, I will just plug the Street Medicine Institute Student Coalition. We are a group of students dedicated to the provision of healthcare to people experiencing homelessness, healthcare, and social services. You can join the Street Medicine Institute Student Coalition on our website. We'll also follow up with information on how to join that. And then I'm just going to ask Dr. Barocas or Melissa, whichever of you can think of other useful resources for medical students to learn about healthcare for people experiencing homelessness.
So, you hit the big ones that I was going to reference. I'm gonna just say that our patients are our best teachers. And there is as many of you know, there's a right way of doing it, and there's a less right way of doing it. Um, we, but I would encourage you, there is literally no better learning, no resource that we could publish that's as good as sitting with your patient, especially as a medical student. Little secret is that as you move through, you have less time with your patients. This is the time to really know your patients, know their conditions, know their diseases, and before you get bogged down with discharge summaries and all those things that happen in intern year and billing that happens when you're uh, uh, old and gray like I am. Um, and but take the time to buy your patient a cup of coffee and as a thanks and listen. Those are the resources that I think are the most valuable for you at this point.
Wow. I couldn't have said it better, and that just hit home in so many different ways. That's exactly right. You have to know your patient, just get to know your patient, even on a personal level, especially if you're meeting them in the street setting. Hold space for them. Let them tell you what they need and what they want, and honor what they want, and honor where they're at. Ask them what their goals are. Get personal. Ask what their goals are. Ask them what they see, where they see themselves, what they want to do, what they don't want to do. We don't want to shove something down their throat that they don't want because we feel like that's what they need. Get to know your patients and get to know their goals, get to know their wants, their needs, and hold space for them so they can confide in you. Because they don't have anybody else to talk to out there. They can't talk to their fellow campmates because they will get all through camp, whatever they're talking about. You are their link to re-entering and empowering and becoming back to life, like basically lifting up and out of where they're at and getting them moving forward and with their health and with their life, basically. So you need to get to know them. That's the best advice you could possibly give.
Thank you so much for both of your responses to that question. I'll also plug two fantastic TED Talks on what it's like to learn from patients experiencing homelessness and how that developed the practice of street medicine. But one is by Dr. Jim Withers and one is by Dr. Brett Feldman. With that, I just wanted to thank you all so much for joining us tonight. And we're going to have, as I mentioned earlier, a follow-up document that you can use as a toolkit that will be sent out to all who have registered. And I believe it will also be available on the event page. Look out, there are some QR codes in that document that you can use to really enhance the care that you're providing to this population. So with that, I hope everyone has a wonderful evening. Thank you very much and good
Thank
night.
you all. Thank you all.